Hi everyone. I'd like to thank Phoenix, Marilee, and Sonia for inviting me to speak on this day 4 of this fantastic AWE week. The title of my talk is The GERD Battlefront in 2024. These are my disclosures. In talking about GERD battlefronts, it begs the question, which battle should we actually be fighting? Is the battlefront surgeon versus surgeon? Should the fight be which surgical fundoplication is best? Is Nissen the best? Is the Door anterior fundoplication best? Or is the Toupet 270 posterior fundoplication best? Or Watson or Omega and others? Or should the battlefront be GI versus GI? Now that we have endoluminal approaches to GERD, should it be the fight between stretta versus TIF versus suturing versus resection versus ablation? Or should the battlefront be between the surgeon and the gastroenterologist? Should GERD be a laparoscopic robotic approach? Or should it be an endoscopic approach, like with TIF? In the next few minutes, I would love to share with you some perhaps new perspectives, including understanding GERD anatomy and physiology, what's up with TIF and CTIF, what about the other endoscopic approaches, so that we can come to a uniform conclusion as to what the real battlefront for GERD should be. So what is the most current understanding of the mechanisms of GERD and the GERD anatomy and physiology? Well, first, we all understand that there are essentially two valves or two anti-reflux mechanisms that protect us from reflux. One is, of course, the lower esophageal sphincter, and we'll go into a little bit of detail about that. And the second has to do with the diaphragmatic crura. Let's first take a deeper dive into the LES. The LES is perhaps a misnomer, and perhaps we should call it the EGJ sphincter because the LES actually includes the gastric sling fibers, which make up the GE flap valve. So as you can see here, the distal esophageal circular muscle is part of the LES, but it's contiguous with these sling fibers of the stomach, which are the gastric portion of the LES. So on the right, you see these gastric sling fibers creating this lip-like appearance on the retroflex view, and I've highlighted that with these purple marks. And if I rotate that a little bit, you can see the correlation between the purple lines on the right and the purple line on the left, indicating the presence of these gastric sling fibers. So the importance of the sling fibers is that when they contract, they don't just squeeze the lumen, they actually move the flap valve from greater curve to lesser curve in that direction. And that's the same on the right side. The movement is from greater curve to lesser curve. So we have the crura, and we have the LES, which we just talked about. Let's talk about the GE flap valve, which is a muscular mucosal anatomic structure. The GE flap valve works in similar fashion to another flap valve that we have lower in the abdomen, which is the vesico-ureteral junction. When urine fills the bladder, it will actually compress on the flap valve, creating a one-way flow from the ureter into the bladder and prevents reflux back up into the ureter. If that flap valve is nice and long with an angle, there's no reflux. When that flap valve is short with a more obtuse angle of approach, there's possible reflux. However, if the tunnel is short and it comes in almost at a right angle, that's almost a guarantee for reflux. So if I take that letter C and I flip it, that looks very much like the esophagus going into the stomach with the loss of the angle of His and loss of the integrity of the G flap valve leading to GERD. So what are the factors that comprise an intact and mechanically functioning GE flap valve? They include the diameter of the valve, the length of the valve, especially the intra-abdominal length, and the movement, which is medial lateral movement from the orientation of the greater curve towards the lesser curve. So when we consider the anti-GERD procedural options, if the patient has a hiatal hernia or they need a crural repair with an open diaphragmatic hiatus, then the options are on the bottom of the screen. They can get a total fundoplication with a hernia repair, that's a Nissen. You can pair a magnetic augmentation with a hernia repair, that's Lynx. A partial fundoplication, that's Toupet, Dor, Watson, Omega, and others. Or you can pair it with a TIF, and that's the concomitant hernia repair plus TIF. We call that C-TIF. If they don't need a hernia repair, then some of the endoscopic options may be quite appropriate. That includes the esophagus TIF procedure. We have others, maze, wrap, arm, and ARMA, as well as potentially the Stretta RF procedure. Moving on now to talk about the endoscopic treatment options for GERD. On the milder end of the GERD spectrum, some of the endoscopic approaches could be used as a primary approach, whether it's Stretta or TIF. Also in patients who've had altered anatomy, such as post-esophagectomy reflux, as well as post-sleeve gastrectomy or post-gastric bypass reflux, some of the endoscopic treatments may become the only alternative to treat these patients with GERD. And a lot of that can be done now with endoscopic suturing in combination with ablation or resection. Over the past decade, I've been helping to develop and perform and teach the transoral incisionless fundoplication or TIF procedure. We found that the TIF procedure actually creates the optimal GE flap valve and augments the anatomic mechanism of GERD. This is the suture pattern that we're trying to achieve to create a 3 up to 4 centimeter length valve, a partial fundoplication that's at least 270 degrees, sometimes up to 320 degrees. Let me play the video. So we start with anchoring the tissue anchor in the posterior corner. And here we're going to set the device and rotate stomach around the backside of the esophagus to create a plication on the posterior corner. Typically, we'll perform 2 to 3 plications on the posterior corner with a little bit of a step down approach lower on the valve with each bite. Now I'm rotating to the anterior corner, placing the helical retractor and creating traction to create the valve length, and then rotating counterclockwise to wrap stomach behind the esophagus. And that's the first plication. And now we're going to place a second plication and then a third plication. So 3 anterior plications after the 3 posterior plications. Then focusing our attention to the greater curve, the helix is then anchored and retract to create the nice tall valve length up to 4 centimeters. We take a bite here at 5 o'clock, a bite here at 6 o'clock, a bite here at 7 o'clock, and a bite here at 8 o'clock. So then that's 4 plications along the greater curve to finish that omega shape. Then I go around and take a look to see if there's any visible area that's a little bit loose that I can do some touch-ups. So here I'm doing a couple of plications on the posterior corner. I'm going to the anterior corner. I'm just going to tuck that a little bit with an additional plication. And then I'd like to put a second row of reinforcing suture line, 1, 2, 3 plications. So now the valve is done. Typically this takes me about 25 minutes, and we can come back and take a look at the valve, and it is all completed. So here we see the valve before the TIF procedure. Now it's nice and snug, or immediately post procedure. But I did want to show you what it looks like a year later when the edema has gone and things have healed. This is what it looks like. And so if you compare the baseline slightly loose G flap valve with the 1 year follow-up, you can see the subtle but impressive difference. If you look on the left, the valve length is about 1 centimeter. If you look here on the right, it's about 3, almost 4 centimeters in length. If you look at the diameter here on the left, it's loose, and on the right, it's snug up against the scope. But if you notice the orientation of the flap valve, that greater curve to lesser curve type of orientation is intact. There's no twisting, there's no kinking. And essentially, we've respected the normal anatomy and merely augmented it by creating further length and narrowing the diameter very uniformly. And over the past several years, we've seen expanding indications for TIF, which includes the general GERD population, those who have the Hill 1 or Hill 2 anatomy. We are looking closely at patients who have Barrett's, sometimes with dysplasia, who are post-ablation, post-EMR, and have reached CRIM, and seeing if TIF or CTIF can get them completely off their PPIs. The postponed GERD patient is a sweet spot for TIF, and in that if these patients do have refractory GERD after a myotomy, TIF is a great salvage because typically these folks don't have a hiatal hernia or the need for a crural repair. In patients after or with an endoscopic sleeve gastroplasty, we can do TIF simultaneously. In patients who've had a sleeve gastrectomy or want to have a sleeve gastrectomy, we're finding that TIF or CTIF may work in both of these scenarios. In patients with scleroderma with poor to no esophageal peristalsis, TIF can be a great solution for their refractory GERD. And among young patients who are, say, in their 30s or 40s, who likely will have a redo in their distant future, whether it be 20, 30, or 40 years later, having done a TIF at baseline is easier to redo because of the simple fact that when you redo a TIF procedure, you don't have to take down the fundoplication. You just need to continue and augment because it is an endoluminal procedure, and you just go to the loose areas and tighten further with TIF. Therefore, patients who've had a prior surgical fundoplication and now decades later have become loose, we can certainly have an endoluminal approach to tighten the fundoplication, assuming there's no need for a hernia repair. But perhaps the fastest growing indication for TIF is the concomitant hernia repair plus TIF, which we call the CTIF. So it is a protocolized, standardized approach to creating the flap valve and augmenting it. And because it's reproducible, it is quite scalable. So now let's move on and come to a uniform conclusion as to where the GERD Battlefront truly should be. Looking at this publication in Gastro in 2020, a survey of 71,000 patients, the prevalence of GERD symptoms was 2 out of 5 people. GERD symptoms in the past week, 1 out of 3. And persistent GERD in persons taking daily PPIs is 1 out of 2. So 40% of U.S. adults have GERD symptoms, roughly 80 million. 35% are on GERD medications, 28 million. 55% are on PPIs, that's 15.4 million. 68% of PPI users take it daily, so that's about 10.5 million. 54% of daily PPI users are considered refractory, and that's an estimated 5.6 million people. Well, the question is, how many people get anti-reflux procedures? And the answer is not more than 30,000 anti-reflux procedures per year. And this, I think, represents the true battlefront. Then the real battlefront is we as gastroenterologists and surgeons need to partner and work together. And we need to be on the same page, on the same team, in helping these huge number of patients who are still suffering from PPI refractory GERD. With that, I thank you for your attention.